So, Dr. Reintjes, I think you're going to tell us where this story begins, and I'm going to be your friendly clicker.
Good.
I will do my best to keep up, but again, just tell me if you need to advance the slide.
Sure. So Kansas City is like a lot of Midwestern cities. It's a river town. And Kansas City was first incorporated in 1853. But for 100 years, there was no hospital north of the river. Until 65 years ago, the people of our community decided that they didn't want to have to cross a bridge to get their health care. So they did what neighbors do. They had a chili supper. And they raised $1,000. They went to the mayor and they said, here's your $1,000, build us a hospital. So that was 65 years ago. So over the last 65 years, that little hospital on the hill has grown and grown and grown to serve now 5 counties. We have 25 different locations. In our outpatient experience, we call Meritas Health. We also have a 451-bed hospital that has 49 different specialties, and in combination, we have about 550 physicians serving our community. So what's so unique about North Kansas City is that we were born of our community. We are depended on by our community, but we stand alone. Unlike the rest of the world that has consolidated, North Kansas City Hospital stands alone. Now, to tell you how unique it is, we recently did a strategic plan, and our consultants came in and they said, if you measured the number of hospitals in our country that have 500 beds or more, which is about our size, there's only about 20 left. But we were born from this independent pioneer spirit. And for 65 years, we have enjoyed that independence. But things are changing. There is great consolidation in our region and in our nation. Recently, Barnes-Jewish Health, Washington University in St. Louis, announced that they are going to combine with St. Luke's Healthcare, 10 hospitals in the Kansas City region, to form the largest hospital system in Missouri. And not only the largest hospital system, the largest employer with 48,000 employees. The University of Kansas, my alma mater, is starting to assimilate a number of community hospitals. So they're not only the quaternary academic center, but they're also getting into the community healthcare business. We also have HCA in our community. They have about 13 hospitals. So we have these big systems, academic medical centers, for-profit medical centers, and religious, not-for-profit medical centers, and we have North Kansas City. And if that wasn't enough, we all face the competition from the disruptors, from the for-profit entities like Amazon and Walmart, CVS, and One Medical. But down the hill from our hospital, true, we have the place where I get gas called Quick Trip, but they also have Quick Trip Health. I think you could get a hot dog and an EKG in the same place. So that is how we stand in our community. We stand proud, we stand independent, but we needed a few more arrows in our quiver. So with that, I would like to turn it over to Kristen Guillaume, our Chief Information Officer.
Sure, and I would just tag on to what Dr. Reintjes said. 2 of our communities, 2 of the counties that we serve are the fastest growing counties in the state of Missouri. So no one used to want to come across the river, and now suddenly, in the past few years, they've decided it might be an okay place to establish care delivery. Looking back just a little bit, as we take a peek at January of 2021, we encountered what we kindly refer to now as the perfect storm. So we had just come off of a very grueling implementation during an extension of our EMR to our ambulatory clinics. We had the onset of the COVID-19 pandemic. We had felt really great about transitioning, over to Cerner for our clinics. And then we also had the onset of clinical shortages, administrative staffing shortages that we all faced out there. We noticed that we had several deficiencies in our EHR implementation, and we had been granted a gift from the state that you'll hear about in just a moment. So we had several issues looming, and we needed a near-term solution with requiring very little resources very, very quickly. We couldn't accept our status quo. We couldn't rest on our laurels. We were done optimizing what we could with some of the challenges we had on the fringes of the EHR. And so we were searching for a partner. But we weren't looking for a point solution, if you will. We were really looking for a partner that could help serve us in a number of different areas as we looked ahead. About this time, we also had the advent of our strategic plan, which was our first strategic plan as an organization that Dr. Reintjes decided we need to endeavor upon during the pandemic as well. As part of that charge, we wanted to focus very, very heavily on the patient experience and the digital experience. So as we looked at partners and consideration of our EHR partner, the partners that our EHR provider had out there, we looked to improve the patient experience, to reduce staff burnout, improve financial performance, and improve care quality, of course. So, just a few easy things to go get from one vendor out there in the marketplace very, very quickly. And
in the middle of a pandemic,
while we're throwing baby monitors to ICU, beds and so on and so forth. And Dr. Reintjes, he's patient, but he likes to get things done very, very quickly. So a multi-month implementation or a 2-year implementation wasn't going to be an option for us. So with that, we found Notable. And we very quickly, we were very collaborative, but we were like a sponge, right? So we very quickly assimilated to realize that there was so much potential that this platform could bring us, and that there really were solutions, beyond this one problem or these two problems that we were trying to look to achieve. And even better, we could do this very expeditiously. Having a small IT team and being a small health system, we're very, very nimble. And so we got very enthusiastic about it, and we got very excited about moving fast. And I'll let Dr. Beardman tell you a little bit about how fast we actually went.
Okay. So if you can rewind your brain just a little bit into that, winter of 2020, January of 21, COVID vaccines had just come out. You probably vaccinated your staff maybe in November and December. And you mentioned that we got a gift. We were gifted a job by the state to be one of 16 high-throughput vaccinators in the state of Missouri. We had no idea how we were going to accomplish this, but we were up to the task. So we partnered with another hospital in our area and our health department, and we figured out very quickly that we needed more help, and so we partnered with our EHR vendor. So we mentioned that we're from Kansas City. We're actually from North Kansas City, and the previous headquarters of Cerner was divided from our campus by Walker Road. So North Kansas City, Walker Road, Cerner World Headquarters.
Vacant
currently. So we used one of their facilities, and they really unlocked a lot of doors for us in the technology space to be able to pull this off. Part of the challenge was we had a list from our county health department. And I think, Dr. Reintjes, it was how many patients?
So Todd talked us into doing this mass vaccination center. I was totally against it. I want to be on the record. He sent me the only email in my 3 years as CEO that started out with, "Dear Steve, you are wrong, period." And there was some Todd. I thought, how in the world, if Missouri was going to have 16 high throughput centers and there's 5.5 million people in the state of Missouri, how are we going to do this when our hospital was full with COVID? So I talked to the health director for the county, and I said, okay, we set this up. We go through all the work of setting up a vaccination clinic. Is anybody going to sign up? And the health director said, oh yeah, I have 45,000 people already signed up, ready to be vaccinated. And I said, well, how are you going to get a hold of them? And he said, I don't know. So I'll give it to Todd.
The data quality was lacking. We did not have date of birth. We had some names. And so it was a real challenge to us in how are we going to outreach these patients. We had been talking with other health systems in our area that got their supply of vaccine about a week ahead of us. And they said basically it crashed our patient portal or our call center could not handle the volume. And so we knew we were already in trouble. So we had been talking with Notable for a period of time, and Pranay was kind enough to say, we'll partner with you on this. And so we had 4 days from the notification from the state to stand up this vaccination clinic.
And our EMR supplier had other things in mind.
That's right. So our EMR supplier had an established set of partners in this space, scheduling and registration. And so Kristen, in perfect Kristen style, said, great, we'll have a bake-off. Whoever gets there first gets to do it. And once they realized that our timeline was 4 days, they said, there's no way we can meet this. And so, Pranay, I know that Connor is no longer with the organization, but there was a notable employee named Connor Pardell, who basically spent, I think, 18 hours a day with me on the phone, as well as some notable engineers. And we pulled this thing off, and we vaccinated just under 100,000 people in a short span of time. Yeah. So that span from January to May was that vaccination effort. In April, we looked at each other and said, I think we should do this to help our staff in our clinics. And Dr. Reintjes agreed. And so we signed our contract in April of 21. By the end of May of 21, we had all of our ambulatory clinics up on kind of that base foundation of scheduling. And from there, it was really breakneck speed to get through some clinical intake, copay and balance collection, all those pieces of functionality that you've seen yesterday or today, or you may already have live at your organizations. But we were surprised by the pace at which Notable can move. We were accustomed to EHR projects, which are, I would say, plodding, 12 months, 18 months, 2 years. And so it took some adjustment for us to get really comfortable with that pace. But once we did, we were able to hit our stride very quickly. So we went through the basic ambulatory registration process. We jumped right into scheduling. And then we started care gap outreach. And then shortly after that, we went into our hospital outpatient departments, things like radiology, pain clinic, et cetera. And as new problems have come along, we have looked to Notable to partner with us to find solutions. And so that's the beauty of it for me, is that we have a toolkit within the Notable platform that we can solve our problems with. It's very flexible, and we've used the outreaches for a variety of things, not just what was intended. So that's been a real important piece for us. But right now we're working on prior authorizations, kind of the simple submissions, radiology studies. We're getting ready to expand that here in the next month or so. And then we do have Digital Assistant live as well. I think Dr. Reintjes always says to Pranay, we want to be first at everything. I think we missed out on Assistant to our MIT colleagues, but we do try to push the envelope as much as we can.
I have 2 metrics for success with this relationship. And the 2 metrics are, how do our people like it and how do our patients like it? 50% of our patients are Medicare age. And after a very short experience in our clinics, I found out that for people over 65 years of age, 70% of the people would register using the Notable platform. And I also asked the question, how do our people in the clinics like it? And that was in the 96 to 98% range. And I said, well, how long did it take for our people to be that satisfied with Notable? And I remember what you said. You said 24 hours. I couldn't believe it. I still don't believe it.
Yep. Yeah, I think there was a lot of anxiety initially around, is this going to replace my job? And I think people quickly understood that that was not our intent?
So the theme here was, one, get it all done really fast and doing more with less. So I think we came from a place in our relationship with Notable where we were looking to be more efficient throughout the health system, whether that meant, we couldn't find people to fill positions, or we weren't able to fill positions, or we didn't want to spend 10 steps and 20 minutes doing a task that we could automate consistently and would provide us more time to devote to patient care. And that's essentially what it's all about.
Mhm.
So with regard to that digitization and improving the patient experience, I think someone's already mentioned today the enthusiasm and excitement around the scanning of the insurance card. So every tenet of the experience is really held to be of ultimate importance to us, because we want it to feel natural for our patients to go through a workflow. We don't want them to pause and think, why am I doing this? Should I be doing this? Why is this? I don't know if I'm doing this correctly. So it's truly intuitive and becomes more so with every project that we endeavor upon with Notable. So we were elated at the insurance card capability. We work through these workflows to refine them and enhance them on a regular basis. We don't have a myriad of team members in our organization that are dedicated to Notable. You would wonder how much time Dr. Beardman spends on it, but I would tell you that he has many other responsibilities that are higher order in the organization. And he and Sydney Tobin, our project analyst, in the audience today, essentially carry the most significant staffing responsibility with Notable. So we don't have a big team dedicated to this. We are very efficient. We leverage the resources that we have that work from an operations standpoint on a daily basis, and they know their processes. And we deliver not what the solution should do or could do, but we look at it from the patient's perspective with regard to registration. If I've already filled out all my information, I don't want to fill it out again. I just want you to say yes. I just want to say yes, it's the same, if you will. If I've already uploaded my insurance card in the past X days, yes, it's the same. And then with regard to copay, we would love to capture everyone's copays along the way, but we're not always able to do so. And then if I schedule my appointment and happen to need to reschedule it at a later date, I want to have the same ease of use in that regard. So the patient experience is of utmost importance to us. And with that, you've heard some references to satisfaction, I'm sure, over the past day or so here. But organizationally, we've heard feedback from staff and from our patients that it was so easy, we couldn't believe it. We couldn't believe we didn't have to fill out the clipboard, if you will. Mm-hmm. And although I did not make my goal of 20% of primary care appointments self-scheduled, we did hit 16.2, which we're very proud of, and we will hit 20. So, but it's not just the patient. As I said, it is about the staff, and our staff are burned out. They were burned out. They are looking for more efficient ways. The whole impetus of our relationship with Notable surfaced from a very painful experience that I had doing time studies at our front desk of our highest volume clinic. I did time studies for about 4 days, and I watched our front desk staff take sometimes 7 minutes to register and take a patient. And that is just not acceptable. While patients were wrapped around the building wearing masks, that couldn't go on for very long. So we think about our staff, we get their feedback, we get their input as we go, we hear their hesitancy, and then oftentimes we serve up, the more efficient model or view. And they were looking for the work list at first. They were looking for the exceptions and trying to find the holes in the system or the workflow, if you will. But they have grown to really appreciate it and to love it. So we're happy to be able to take some of the burden off of them. And we have We have not filled many positions in the organization to date. The hesitancy that was seen or heard from one clinic to another, you don't hear that anymore. Organizationally, they're all very accepting. We are the ones now responding to the list of, can we do this? Can it do this? How soon can we go in this direction or that direction? So Notable is very accepted, and we're very happy. We have one of our most challenging practice managers quoted here. When Notable is complete, it's heaven. This is the same woman that told me explicitly that she's implemented an EMR before, and I don't know how to implement an EMR. So that was a big reward to hear her quote.
It's important to note that we were deploying Notable at the time when our workforce was most challenged. Now, I've said that our outpatient enterprise is called Meritas Health. The average number of employees that we have in Meritas Health pre-pandemic was about 700 employees. But we had about a 14% vacancy rate. So we were doing the same amount of clinical work with 600 employees, but the stress on that group was very high until Notable appeared.
Yes. And Dr. Beardman, I'll let you touch on some of the financial performance.
Sure. So we've really seen a pretty significant improvement. And I would say, and we'll get to it in a slide here, but I think our no-show rate is the thing that stands out to me the most. We were really surprised at how quickly that no-show rate declined. Obviously, I think the pieces that you're seeing on the screen, the confirmation and the completion of the copay, they build an investment on the patient side where maybe a text reminder is not the same level of investment. I've started my pre-reg, I've completed those steps, I'm more likely to keep that appointment. I think that stickiness is really helpful in keeping that no-show rate down. So I think when you talk to our staff, obviously our no-show rate fluctuates a lot, but when you look at it longitudinally like we did for this purpose, it was dramatic how quickly it went down and how far it has stayed down over that span of time. So I think that gets to that 34% reduction in no-shows is pretty significant. On a side note, we talked about the completing Notable. I don't know if there's any English majors in the room, but if you can help me diagram the sentence that I get asked the most often, which is, did the patient do Notable? Is that a helping verb? I'm not sure how that goes, but that is the number one question we get is, did the patient do Notable? So there you go. English major, you can find me afterwards and let me know how that works. One of the pieces that I'm probably the most personally invested in is our care gaps. Previous to our experience with Notable, closing care gaps was very, very difficult. It was left to each individual practice to call a list, a work queue of who needs a mammogram and who needs a colonoscopy. And mostly we dealt with the patients that were in front of us. And so if you weren't in front of us, your name kind of fell down the list a little while. And obviously that's not great for our patients. That's not great for us. It's not great for population health. It's not great for our payer contracts. There's a lot of reasons that we obviously want to do better with that. So we started looking at how can we use the Notable platform to outreach these patients, and many of you are doing that today as well, care gap outreach. So we send currently 6 care gaps every month to our patient population, and we break it up so that each individual patient only gets notified twice a year on an individual care gap. So if you're missing your colorectal cancer screening, I'm not going to bother you every month, but I'm going to bother you twice a year until you get that thing done. And it has made a big difference. I think if you want to go ahead to the next one, we've seen across all of these care gaps, significant participation from our patient population, which I didn't really expect. This is the equivalent to a cold call saying, hey, your diabetes might be out of control. Do you think you want to come see us? And so doing it through the the Notable platform, I think, takes away some of that judgment when someone is behind on their screenings. So I've been impressed with our patients and what they've been able to work with us on to drive these outcomes. So we're showing you the total number of care gaps that were closed or expected to be closed. But I think if you go to that next slide, this is the one that probably it tells the story the best. So in that first year that we did mammography outreach, I was very meticulous about talking to our radiology department. Okay, how many patients showed up? How many biopsies did we do? How many diagnoses of breast cancer did we make? And so in that first year of mammography outreach, we had 6 women who were diagnosed with breast cancer that had gone through the Notable Care Gap outreach experience. So these weren't women that called up and scheduled their mammo or scheduled online, or they were referred by their physician. These were people who were probably going to be lost to follow-up. And those 6 women all had early stage cancer. And that's the whole point, right? That's what we're trying to accomplish. So that one, we're very, very proud of that step. The other piece that I mentioned that is hard for me to think about sometimes is the payer part. Sorry.
I think about it a lot.
It's not always first on my mind, but I realize that it's important. When we started, we thought, okay, how is this going to play out with the payers? Obviously, they hold a lot of the data. They tell us how we performed, even though we think we know how we performed. It's always a little back and forth. So I took our data, I took their data, and we have meetings every month, just like I'm sure you do, where we go over those performance. And I looked middle of the year this year and said, let's look compared to last year. And across each one of these, we saw a significant improvement in our performance for our population health metrics. So we were really glad to see that process play out.
So I have had discussions about the community we serve, and I already mentioned that we're bound by a river. Well, the river actually bounds us to the southern border and to the western border. So the population in the Northland, they describe it, Games of Thrones, like the Northland, is unique and geographically distinct. And the payers have come to me and are now wanting to engage upon population health studies because of both our geographically distinct population and our success in these measures.
Yeah. These slides are just some more of our performance. Again, remember that these are mid-year performance numbers, and so they will go up through the month of December. And so we have great hope that we will achieve across all of these metrics before the end of the calendar year. Dr. Reintjes?
So we think about our community. We were born of our community. We have served our community proudly. We have a very close-knit group of doctors and nurses and support teams that really identify with this mission, the mission of a community hospital to serve the needs of the community, whether it is a vaccination process. And I want to give kudos to Todd back on the vaccination thing. About halfway through, I said, Todd, how are we doing on this Operation Safe? He said, we're just hitting our stride. I said, well, what does that mean? He said, we're vaccinating 81 Missourians every 10 minutes. And that's good work. So what we're trying to achieve is this. It's very simple. How does a hospital born of its community, whose community expects us to be around, that expects us to be local, how do we continue with that mission? Well, we have very simple goals. We want to improve the patient experience. We realize that it's different now than when Todd and I went through medical school. There was a physician-patient relationship, and we recognize that that is morphing to a consumer-physician relationship. We're now competing with hot dog sellers down the hill. I mean, it's challenging. And we did a study halfway through the pandemic about who would a patient prefer? Their legacy physician, if they had to wait a week for the appointment, or an urgent care center that they could see in 15 minutes? And the overwhelming winner was somebody they could see in 15 minutes. So we want to create that patient experience. Notable helps us increase access, but it also does this. It improves the overall quality of the experience. We now have online scheduling 24 hours a day. And I love seeing the graph that you put up, because I love seeing the people that schedule their appointments at 2 and 3 and 4 o'clock in the morning. And people think, well, that's the night owls. No, it's somebody who wakes up in the middle of the night with a sick kid, then doesn't want to have to go to the ER to pay that high cost of the ER. Or it's somebody that wakes up with a bellyache or shortness of breath and says, well, I can make it to the morning. So we want to improve that convenience factor, that consumer experience factor. 2, we want to offload the burden for staff burnout. We recognize that the next decade, we're all going to be challenged with the availability of physicians and nurses. But I think the workforce is challenged now for people that need to come to an office to serve their fellow man. So lessening that staff burnout will allow us to fulfill our mission. The third goal is to improve our financial performance. And this is what I believe. We as a community hospital, if we can show our quality, that we can win with the payers. Because just to go back to my second slide, we have a large academic quaternary medical center that is very expensive to go to. We have a large network of for-profit hospitals that is very expensive to go to. And now we have a merger between the 2 largest health systems in the state of Missouri, which is very expensive to go to. So I believe that North Kansas City Hospital, Meritas Health, can be the high-quality, low-cost producer, and that equation will provide a sustainable financial performance for the next generation. And then, fundamentally, improving the quality of care. I want to be able to stand up to my larger brethren in our community and say that our quality is as good or better and more nimble and more patient-centric than anyone else in town. But it all centers around quality. We have a community to serve. So that's our goals.
So I have actually heard this story quite a few times, obviously have seen the slides several times, and I always learn something new, and just to hear you all bring the story to life is just incredible. I think there is such a lesson about courageous leadership and embracing change while getting your entire organization rolling in the same direction. So before we move to Q&A, I just would love for everyone to give this crew a round of applause. Okay, are you ready to take a few questions? Let me tell you how this will work. So first of all, I actually want to invite one more member up to the stage, so you now know the reason for the empty chair. So I'd like to bring up Dr. Hung from MUSC, who's going to share really how many of these same themes come through at MUSC in Epic Shop. So thank you, Dr. Hung, for joining us. And I will give you all just a moment. There will be 2 mic runners in the room. If you would like to ask a question, and I really hope that you will, just raise your hand or give the mic runner an anxious look, and a mic should come your way shortly. But while you all think of your questions and while the mic runners have a chance to get to you, I want to actually throw this first question to you, Dr. Hung. So we have heard in this presentation a lot about automation as really serving as the foundation for the quadruple aim, and has really propelled North Kansas City and Meritas Health to new levels. But how does this play out for you all at MUSC?
Well, first I want to thank you, Chair, for having me, and congratulate Stephen, Kristen, and Todd for a great presentation. I just realized sitting up here, actually the questions are up here on the screen here, so none of you can see that. So I was trying to listen and look at the screen at the same time. But Maybe a few comments just in terms of what resonates. I want to start maybe with something that we had a different experience at MUSC because we did not have the fortunate case of working with you during COVID. So I'm a little sad and happy at the same time, actually, that we didn't partner with you guys a little earlier because we were also the vaccinators for the state of South Carolina, and that was quite an experience. There were two other areas, though, where I really enjoyed your presentation in particular because we're a little bit less further along on this journey. We've started maybe in a meaningful way 2 years ago in terms of partnering with Notable at MUSC, but that we really got into the digital pre-registration just at the end of last year, and we've already had 1 million patients sign up, and it's not even a full year. As a physician, as a physician leader, I was naturally skeptical of anything new, but it's been a very, very positive experience, and we only look to make continued improvement there. And the other thing I would mention, by the way, we have a 97% satisfaction rate, so Stephen, I would say your experience mirrors our own as well. The other thing that really resonated with me in your presentation was our ability to lower the no-show rate. And we went from 9% to 7%. I think Pranay put up 14% reduction, but the absolute numbers were 9% to 7%. And if you really want to bring a tier to an operator's eye, as Pranay was talking about earlier in his introductory remarks, or a tier to a physician executive's eye, tell them you're going to lower your no-show rate. And when we have 2 million ambulatory visits a year, those are not insignificant numbers. So those were a couple of things that really resonated with me with your presentation and have echoed our experience in this partnership.
Any questions in the audience? All right, looks like you are still thinking. So I will throw one more Kristen's way. Kristen, tell me what's next on the roadmap as we all continue our partnership together.
Well, we have a list. It's very long, and it continues to grow while I'm sitting here. We're looking at HCCs. We're looking how to do more with the platform from a population health standpoint. We're looking at surgery workflows, and we're very excited about doing more things with the platform on our own. Sydney and I were having side conversations just a few moments ago, so we have a lot of big ideas.
Dr. Beardman, anything you would add?
Oh, I think that's right. I think return to clinic is something that our practices have been asking for. The automated outreach after you complete a visit to schedule that return. I think that is something that's on our short-term list. I think it drives some of that compliance, again, if you use that pathway. Our surgery workflows, I think, are really important. We spend a lot of time, as I'm sure all of you do, in the pre-surgery clinic area, and that's something that we feel like deserves some time and some automation.
So it looks like we have our first audience question.
Hey, Jason Mitchell. I'm a family medicine doc from Presbyterian, New Mexico, and the chief medical officer. So you've done amazing work, all of you, and then I'm going to ask, well, what's next? And what I'm asking, and it goes to what you were just talking about, is in the inpatient setting. So as you go in and out of the hospital for surgeries, the ED process through, that's a place where we're so archaic from automation standpoint. And so have you all started to think about that? And I realize your practices are different, but have you all started thinking about that crossover to the inpatient space?
We've begun that, but I'm going to defer to Todd on how we are being.
Yeah, I would say that when we rolled out pre-registration across our hospital departments, we had a very interesting wake-up call that we have no idea at the variety of workflows that happen across all of these departments. And so it was very enlightening for us to dig into these. And the surgery workflow in particular is very complicated. I'm not going to tell you anything you don't know. We have surgeries that get rescheduled 3 or 4 times the day prior to surgery just to adjust the schedule block. And so how do you outreach that patient with the right time to arrive? So that's an area that we're working on right now as far as the clinical intake. We solved the arrival time by saying, you're showing up at this time, and we don't pay any attention to the actual surgery time because it changes too much. The ED, we have not dipped our toe in that water. I do see lots of opportunity there. On my side of the fence, I would say we need better FHIR endpoints for the speed at which we need to document the data. Since we're in Cerner, we use PowerForms and iView for nursing, and those are RPA jobs today, which are great. They get things done, but they're not fast. So 10 to 15 minutes to get those in. If we had FHIR endpoints, it's immediate. And so those patients could have their intake done very, very quickly. So I think that's something that we look forward to if our vendor can help open the keys to the kingdom on that one.
I'll maybe add a couple comments. Jason, I appreciate the question. I know we chatted briefly during the break. As a primary care doc, I'm sure you could appreciate the transitions in care are really important for our patients as they go pre-hospitalization, hospitalization, and post-hospitalization. But I'd love for the ability for this partnership to allow us to improve having a patient leave with an appointment, leave the hospital, being discharged, have their medications in hand. And if they don't make their follow-up appointment, that there's some system that doesn't require human touches that helps ensure the follow-up. So those are just some things off the top that this partnership could help, and technology can help us improve patient care and quality of care.
I will tag on one more piece to that, and your comment about transitions of care really triggered it for me, which was we're using the care gap outreach functionality today for our primary care patient base. If they go to the ED that next day, they're getting an outreach that says, hey, let's schedule that ED follow-up. Yeah. And I think the next step to that is what you just alluded to, is show me all the people who fell through the cracks. And we're still doing a manual process for that today. So extending that behavior would be great.
Yeah, a personal example of that, Todd, for me would be identifying the people who need a bone density scan after they've fallen and had a fragility fracture, right? That doesn't happen in the hospital setting. It has to happen in the outpatient setting. And how many patients do we miss out because we just don't have the technology to support that type of care that we want to deliver?
Dr. Reintjes, I have a question for you. So I think there are folks here who are earlier on their journey with Notable, some of whom are trying to actually bring Notable into the organization. And, they might be a chief digital officer, a chief information officer, even a very senior operator who is charged with bringing their CEO along for the ride. So any thoughts on how to help them make that business case and how to articulate it in a way that the CEO is really going to understand the value?
I think that I don't come from a traditional background. I was never an administrator. I was a neurosurgeon until March 20th of 2020, and 2 weeks later I was a CEO. So I don't have those, predetermined processes in mind. I'm a surgeon, and you give a surgeon a knife and he cuts. So good
to know.
No, I'm serious about the decision making. Mm-hmm. And you take the data, whether you're making a diagnosis or doing an operation, you take the data, and the data as a surgeon is the physical exam data, the history data, the imaging data. Well, the decision-making as a CEO is the same. You take the effect on the patient, the effect on the finances, the effect on our people, our processes. And when you have talented team members and they present for you the answer for people and processes and the impact on finances, it's easy enough to pick up a knife.
I'd add to that, we have a fairly rigorous business review that we conduct, and Dr. Reintjes oversees the results that we're driving. And it's only through our execution that we've essentially earned the right to go do the next project. And we are tracking the baseline and the forward-looking measurements as we go on every endeavor that we pursue. So it's definitely a justification process, but it has created a flywheel opportunity for us.
Can I just add one thing? Because I was reflecting on this as you asked your question, Sarah. I like the remarks earlier this session that talked about shared values. And one in particular for me, and I think would be helpful, at least for our organization and probably maybe others, is that in healthcare, we're in it for the long term. We don't always hear that or get that impression from our partners. And it's been a nice partnership in terms of shared values. That's helped us, I think, move forward.
And I think Kristen's right. We we do set the expectation that any endeavor, any capital expenditure, any new process, any new program, that we not only need to understand its impact on our people and our patients, but also what it does for the system in terms of sustainability. And I've been very pleased with Notable's return.
Well, I think that is a fantastic place to end our talk, unless there are any other questions.
Sure.
Oh, Pranay,
You know my question. Do you want to ask it?
you ask it.
First of all, I just want to say thank you for your support and help in getting us to be better. It's not always a smooth ride. I would love, maybe this two-part question. One, what are the things that we have done to push your organizations forward that we should continue to do and recommend to others to do? And then the second part is, what can we as a company do better?
I'm going to take the forward look. You can take what they can do better.
Okay. Go ahead.
In terms of the forward look, take on the hard things. Pre-authorization is a hard thing. I had a cup of coffee with the head of one of our larger payers in Kansas City, and they were struggling with pre-authorization. And, we consume a lot of man hours pre-authorizing simple things like tests and therapies and things like that, and finding that solution. So I would extol Notable to continue to take on the difficult task, to climb the steeper mountain, because healthcare is hard, and we win if we take on hard things.
I would say that we're really glad that Notable is growing, and sometimes that means there's some turnover, and we have to re-educate new team members on places that we've already been. So again, we're really glad Notable's growing, but we do have some opportunity where we have some turnover and we need to re-educate. So that takes a little time. I would say that maintain your humility and your communication styles overall as an organization with our organization and our various stakeholders are very strong in comparison to other vendors. So whatever you're doing and however you're educating or trying to educate staff or new members of your team is working. So I would continue to do that.
Yeah, I would echo that. One thing that we talked about in the presentation was the push to make us more agile, more nimble. We already felt like we were, but apparently not. So I think that should continue. I think the humility is really a unique thing in this space that we don't see very often. But the number one thing for me has been that you don't behave like a vendor. You behave like a partner. And that carries a lot more weight for us, helping us solve our problems, not find a use case for something you have to sell.
Thanks for the question, Pranay. I'll say three quick, hopefully practical things. The first, actually, in terms of looking backwards and the opportunities and things we've learned. This is actually not on our Notable partner side. When we implemented digital pre-registration for a number of months afterwards, we still had staff in the office still going through the registration process. That's on us, and we've been working to correct that, still are working to correct it. So we didn't immediately get all the benefits of all 1 million patients registering digitally ahead of time. We were still actually having people check things off on paper as they walked in. That's getting better, so that's a lesson learned for us. The second thing, actually, in terms of our experience the last year has been that when we brought up the issue of a patient having multiple appointments in the same week, so then they were being asked to digitally pre-register multiple times. That actually has been addressed thanks to people in this room working on that project. So the patient only checks in once for multiple appointments. So that was very helpful. I know it may sound small. Looking forward, actually, again, staying very practical, if you really want to see me break onto full tears, Pranay, fix in-basket messaging, please, for the providers. If you ask your providers, that is the number 1, 2, and 3 pain point for them right now. So that has no immediate solution. So in-basket messaging would be my wish and ask.
Well, stay tuned, says Pranay. So a huge thank you to Dr. Reintjes, Kristen, Dr. Beardman, and Dr. Hong. Thank you.